one of the things about prevention research that's interesting is there's lots of data to suggest that it's highly cost effective, but the cost savings often show up in a sector different than the one in which they're delivered. So if you do high-quality daycare child care, high-quality nursing visitation, you have better medical outcomes, you have better outcomes in terms of staying in school or less antisocial behavior, but those interventions are delivered in either schools or daycare centers in the age group 0 to 5, and the savings are in the juvenile justice system and in the school system 10 or 15 years later. Therefore, prevention requires a long-term shared responsibility for the future of children. Now, I've been doing collaborations with Costa Rica, Finland, Holland, and Norway, and I would love to do collaborations in Canada. I've done some. And what do those countries have in common? They have in common a strong national health care system. And with a strong national health care system comes the shared responsibility over the long term. And I'm, despite all the problems, I'm very hopeful. We in Massachusetts now have passed legislation for health care for all and for parity between mental health care and physical health care. And our remarkable new president, Barack Obama, is very strongly interested in health care for all. So we may in the States get there. Now, many of you in this audience could talk more thoughtfully about neuroscience than I, but I think that from the advances in developmental neuroscience, and even from the new technologies, genomics, neuroimaging, has emerged the fundamental idea of developmental plasticity. That is, where we used to think that across development, be it from genetic effects or from insults to the developing nervous system, deficits were fixed. We now realize more and more that either at the cellular level or at the whole body level, there's a plasticity across development and an ability to compensate, to hit obstacles and work the way around. So I think really developmental neuroscience makes a very powerful case for why we should invest in prevention. And in the IOM prevention report, which I referenced and gave you the website link for at the end, there's an excellent chapter on developmental neuroscience. And again, we now know that genes profoundly influence, the environment profoundly influences genes, and through epigenetic phenomenon, the environment can be passed on. That environmental influence can be passed on, so that we have every reason to be thinking positively about prevention. Thinking about the IOM, I served on a committee with the IOM that published a report in 1994 on the prevention of mental disorder. Interestingly enough, Bob Haggerty, a pediatrician, and Betty Hamburg, a child psychiatrist, were co-chairs of that committee. And I was asked to serve on a similar committee from the Institute of Medicine. This time around, we published our report in March. The Institute of Medicine has a very rigorous scientific procedure in which they assemble a committee, and they're charged with objectively reviewing the evidence. And they usually put about half of the scientists, people who work in the area, half the scientists have nothing to do with the area. So it's a very serious scrutiny. And the two chairs of this committee, neither one of them was preventionists. One was Ken Warner, who's the dean of the School of Public Health at Michigan and a tobacco researcher, and the other was Tom Boat, who was chairman of pediatrics at Cincinnati for many years, Children's Hospital here. But I think in this report, there's very strong endorsements for early childhood intervention, daycare, first home visiting. There, across a whole variety of parameters, there's evidence to support parenting. Parents can be intervened with in various ways, particularly in partnerships. Strengthen their parenting, kids can do much better. There's a lot of endorsement from for social skills training. A colleague of ours, Dr. Weisberg, actually runs a consortium of people who do social skills training. And there's very strong evidence about community interventions. In the city most like Vancouver in the States, Seattle, David Hawkins and the Social Science Development Group at Seattle have done a community intervention that had 3 levels, in the classroom, with families and with the community in 5th grade, and show actual effects on mental health when these kids are young adults. So these coordinated community efforts can work very well. Again, there's a very strong endorsement of families in distress, parental depression, bereavement, divorce. There are a number of studies that show long-term outcomes, and they're classroom-based interventions. And Dr. Lee so kindly mentioned this NIMH study that's looking at a foresight prevention for mental illness, Greg Clark's, using kids at double risk because the kids themselves either have had prior depressions or have symptoms of depression and the parents are depressed. We have an article that will appear in JAMA, the Journal of the American Medical Association, in the first week in June from our 4-site trial, which is 320 kids in 4 sites, and we show a main effect for the prevention, actually preventing episodes of major depression in the group that receives it. So I think we have a very strong science base. In comparison to 94, there's much greater emphasis on implementation and dissemination. We need to learn how not to do things in single trials, which are called advocacy studies, but how to do them in 50 communities or 50 centers, and then 150, and then 500, and then 1,000. And I think there's a number of ideas about how one might go about that, but I think for policymakers, the question is, in my view, you should only invest in interventions that eventually can be widely used and widely disseminated. There's certainly much more evidence now in terms of the quality and the number of trials and the kinds of things that we have a good deal of certainty across different studies about principles. Now, this is an old diagram that I made, and it's very crude. If we were really thinking about development, we'd have to move across time, and she would be much better at drawing it than I. But the point is that we need to think about the child at multiple levels, because if you just think about the circle, there's the child, there's the primary caregivers, there's the institutions that are centered on children, schools, daycare, healthcare systems, and a larger area, social political systems, and culture. And culture is, certainly in my country, numerous cultures are represented, and the issues around understanding cultural humility and cultural competence are key. But both systematic interventions at levels 3 and 4 in schools and in healthcare systems can have huge effects, and certainly on the negative side, as we're wrestling with in the States right now, large-scale unemployment, job loss can have a very powerful effect, but so can effective interventions. So I think we need to think then at these multiple levels as we try to design preventive intervention. But across those multiple levels, I would also say as a kind of leavening, we need to make things very clear to the lay public and the parents that we're working with, and we need to partner with them at every level. And so your involvement in these projects is really crucially important. Now, in each of the studies we've done, we've tried to define depression and resilience in the context and metaphors that particular people we're working with use. So I'll speak now briefly as a physician, as a psychiatrist, trying to think about developing an evidence base for a depression prevention program. What is depression? It's, above all, an illness that carries terrible suffering with it, a terrible burden, and we need to recognize that and address it, because we have perhaps some of the best treatments we have in all of medicine for depression. But at multiple levels, certainly it's a diagnosis, one major symptom, 5 associated symptoms. We think it's probably best understood on the analogy of rheumatoid arthritis. People with depression may go in and out of episodes. They certainly need a regular system of care, more intense care when episodes are coming on. And on the other hand, that the prognosis can be quite good. Certainly it's a rearrangement of neurotransmitter function, growth hormone secretion is affected, adrenal